Welcome to our program. It's titled Effect of COVID-19, XBB1.5 and BQ.1 Subvariants on Immunocompromised Patients. I am Dr. Lou Teperman, Vice Chair of Surgery and Professor of Surgery and Medicine at the Hofstra Northwell Medical School. Predominantly in the U.S. now, we have a variant that's XBB1.5. It makes up in the Northeast about 75% of all the COVID viruses. By the end of this month, January, we expect this virus to be in every state of the union and to be the #1 variant. BQ.1 and BQ.1.1, which had started the fall as the main variants, are decreasing in number as XBB1.5 increases. This variant is called the Kraken, and the original variant XBB1 came from Singapore, and this variant mutated in the Northeast. It is an American variant. Immunocompromised patients are significantly at risk for COVID. They make up somewhere between 3 to 5% of the population. Transplant recipients, individuals taking immunosuppressive drugs, and certainly those with autoimmune conditions make up the immunocompromised group. They are at greater risk because they have an inadequate response to vaccines in general and the COVID-19 vaccine specifically. They get severely ill, have prolonged infection and shedding, become hospitalized, have low antibody and neutralization titers to variants. In fact, their mutation is more than likely what has caused the new variant that we're looking at. It used to be that immunosuppressed patients could be given prophylaxis, not just by taking the vaccine and having a response, but being given a monoclonal antibody, in this case 2 monoclonals, ticks and SIL. It was long-acting against SARS-CoV-2, and it worked. We'd give patients these antibodies separated by 6 months, so they'd be taken care of for a whole year. And the EUA was initially given in December 2021 for pre-exposure prophylaxis. And in fact, some individuals use it as treatment. Clinical trials showed an 83% risk reduction in the rate of symptomatic COVID. Unfortunately, over time, the variants, which are very smart and fit, avoid this monoclonal antibody. We now know that the circulating antibody is no longer effective against XBB1.5, BQ.1, and BQ.1.1. So we no longer use this antibody. It's not effective against the subvariants that we have. We used to have an antibody that was monoclonal that was treating the subvariants. It's no longer effective against these either. So now we're only left with vaccination, and everyone should have the bivalent vaccine, and pharmacologic measures. We know we should also be vaccinated against the flu. We've had this tridemic of RSV, flu, and COVID this winter, so vaccination and masking and distancing are very important. So what should we do? Treatment, you need to speak to your physician. If you're on immunosuppressive drugs, you need to tell them promptly about this. If you're hospitalized, maybe an antiviral should be used. And if you're very sick and not hospitalized, maybe an antiviral should be used. The drug that should be used should more than likely not be the one that contains ritonavir if you're on immunosuppressive agents such as calcineurin inhibitors. There are significant drug-drug interactions that would cause you to go into renal failure. If you're on very high doses of glucocorticoids, they shouldn't be stopped. If you're on lower doses, they may be manipulated. Recipients should not have any medication adjustments done unless they speak to their physician because they're at risk of graft rejection. This should definitely be a partnership with your physician. Thank you for joining me today. For more information on COVID-19 prevention and treatment, please visit the series landing page at exchangecme.com. For the latest updates on COVID-19, subscribe to Exchange CME's YouTube channel and check back regularly. Thank you very much for attending today.